لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله وتلك الأمثال نضربها للناس لعلهم يتفكرون هو الله الذي لا إله إلا هو عالم الغيب والشهادة هو الرحمن الرحيم هو الله الذي لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر سبحان الله عما يشركون هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم صدق الله العظيم.
Welcome address. She is the best graduate from Kailasam University in year 1989. She is Fellow of International Representative Committee of Royal College of Obstetricians and Gynecologists and Executive Member of Pakistan Urogynecology Association. She has done her clinical fellowship in urogynecology and endoscopic surgery from National University Singapore and followed by Diploma in Minimal Access Surgery from France and fellowship in assisted reproduction from University Hospital London. She is very active in conducting and participating academic activities. Please welcome on the stage Professor Nazi Hamid.
A very good morning to all of you. Thank you so much for being in time despite the stormy weather. And we've started a little late because we're just giving margin to people so that they could join us. I'm extremely thankful to all of you who have shown enthusiasm and traveled to attend this academic activity. The 2 days forum that we are going to have, the first day we will be predominantly talking about stress urinary incontinence. Its diagnostic workup, its conservative management options and surgical management options. We will be touching the latest updates and latest trends in it. That will be followed by, we are absolutely delighted to have Dr. Augustina Vendramini here. She traveled all the way from Italy to share her experience with us. I witnessed her urodynamic library at International Urogynecology Association meeting in Vienna, Austria, and that was absolutely wonderful. And she earned a huge applaud over there, and even President of International Urogynecology Association wanted them to share the presentation on the Ayuga website. They are like thinking about that, but I thought it's a good idea that our residents and our consultants, they are always so scared of advising urodynamics and interpreting urodynamics, and it would actually be lovely if we can have
patients visiting gynae outpatient department. This study was conducted in gynae outpatient department of Sharma Hospital, and it was cross-sectional study. The duration of this study was 1st Feb 2018 to 30th September 2018. Failure to conceive, vaginal discharge, urinary incontinence, and other urethrovaginal complaints. And these patients were of age between 40 to 60 years. These were included in the study. And the patients who were not included in the study were those who were less than 40 years and more than 60 years of age. And the pregnant women were also excluded, and the patients who were 6 months postpartum were also excluded from the study. And then these participants of the study were divided into two groups, premenopausal and postmenopausal. And participants were asked to fill the international consultation on the incontinence questionnaire short form. And then the frequency of lower urinary tract symptoms in these patients was recorded, and data was analyzed by SPSS version 21. And here it is flashed that the patients who are having symptoms of urinary incontinence, 40% of the patients were those who were between the age 40 and 49 years. And 59% of the patients were those who were of age between 50 to 60 years. So it reflects the association between the age and the patients who are having urinary symptoms. And this slide just shows the association of the parity, because multiparity and increased parity is definitely associated with increased urinary symptoms. 76% of the patients were found who were Paris women, and 23% of the patients were nulliparous. And this slide shows the association between increased BMI and the patients who are having increased urinary symptoms. You are already knowing the increased prevalence of obesity in our society. And obesity is definitely related with the increasing trend of the urinary symptoms. 80% of the patients were those who were having BMI of more than 25, and 19% of the patients were those who were having BMI of 19 and less than 25. And this slide reflects the education level, association of the education level and the patients who are having urinary symptoms. As education increases the capacity to seek medical advice, so the patients who are illiterate, they delayed their symptoms presentation, and they present late in the health department for their issues. So 62% were those who were educated, and 37% of the patients were less educated. And this is flashed over here, the association of the mode of delivery with the urinary symptoms. And all of you are already knowing that spontaneous vaginal delivery is more likely associated with the symptoms of urinary incontinence and all the urinary complaints. So 70% of the patients were found who were delivered vaginally, and 29% of the patients were those who were delivered by the cesarean section. So increased urinary frequency was found in 48% of the patients, and stress incontinence and urge incontinence was the next most common symptoms among all the symptoms. And postmenopausal were 58%, and 42% of the patients were premenopausal. And then parity was strongly associated with the prevalence of lower urinary tract symptoms. Urge incontinence was the next common symptom. It is strongly associated with the age, and mixed incontinence was also associated with the age. In this slide, we have divided all the symptoms, and 48% of the patients were having incontinence, 17% of the patients were having stress incontinence, 9% of the patients having urge incontinence, and 16% of the patients having mixed incontinence. 39% having nocturia, 29% of the patients having dysuria. And confirmation of the culture was found in 16% of the patients. I will conclude my study by saying that frequency of lower urinary tract symptoms is quite high among the patients who are visiting gynae outpatient department. And risk factors are obvious. These are multiparity and obesity. And the prevalence of obesity is quite higher in our society. Due to socio-economical reason, patients present late in the gynae outpatient department for these symptoms. And all the patients must be investigated thoroughly. So it is recommended that every medical setup must develop a proper surveillance system to determine the prevalence of this health issue in the community. And my take-home message from this is that upstream approach is the need of hour as compared to the downstream approach in the healthcare delivery system. The upstream approach is used in the preventive medicine, in which we have to treat the patient before development of the complication. In the downstream approach that is used most commonly in the third world countries like Pakistan, we treat the patient after the development of complication most of the time. So establishment of a specialized unit in every hospital is necessary to improve awareness, knowledge and training in this area. Thank you. And now I will invite my honorable guest, Professor Farid Zafar. Sir, most welcome over here. And we are highly obliged and it's a pleasure to have you over here. And he is presently president of Society of Obstetrics and Gynecologists in Pakistan. Sir, please welcome on the stage. Please come as a chairperson. And as you all are knowing that Dr. Augustina is with us over here. So people are knowing that interpretation of urodynamics is generally considered a technically difficult situation and challenging component of urogynecology. It's considered equally difficult by range of doctors, including postgraduates and the specialists. Now I will invite my honorable guest, who came here all the way from Argentina for this spectacular morning. My honorable guest has done her degree in medicine from University of Buenos Aires. Currently, she is MD in Obs and Gynae and doing her second year of fellowship in urogynecology at Italian Hospital. The amazing visual library prepared by Ms. Vendramini was presented at International Urogynecology Association 2018 and earned a huge appreciation for its comprehensiveness and simplicity hands in hand. Please give a round of applause and welcome her on the stage, Dr. Augustina Vendramini.
I'm from Argentina. It's a South American country. I speak in Spanish, so I'm going to say sorry my English a bit, but I'm going to try. I came here to talk about urodynamic visual library, and I want to tell you first how this born. This urodynamic visual library, I made it for my residents in Argentina. We often have like 1 or 2 residents from our hospital, that is Italian Hospital of Buenos Aires, Argentina, and we have 1 or 2 from other parts of the Argentina, residents that come 2 or 3 months to do urogynecology with us. And so I decided to make a library to have the most common interpretations, so we could be something more didactic and perhaps quickly in the day. Well, thank you very much for the invitation. I was so happy. We've been invited to other countries from America, and well, we always go to Ayuda, but we've never been, I think, so large distance. So thank you very much, and I'm very happy. Well, I'm going to. I made a presentation, and then I'm going to show you the visual library. That is a video of 10 minutes. But I want you to know that this is a bit longer. It's a very big library where everybody, it's a cloud that everybody can put when they see or they are doing a urodynamic test. If they see something nice to show, they can put it so everybody in the hospital and indeed in other hospitals can watch that too. So it's something quite interesting. And then we have other libraries too. We have cystoscopies, surgeries. Well, we started to make a lot of them because we find this quite interesting for academic stuff. And it's interesting too, to other, Argentina is a very big country with doctors that are all around Argentina, and perhaps you have a doctor alone in 400 kilometers. So what we want is to give a tool, you know, something to quickly, easy to understand, so they can interpret the urodynamics when they read it. And I think it's useful. We believe that. Well, so then as introduction, what everybody knows is that it's a test that are designated to evaluate the function of the lower urinary tract. The most important of the urodynamics is reproduce the patient's symptoms. That's the most important. If a patient comes from a stress incontinence, then the urodynamic is very sensitive for a stress urinary incontinence, so you have to found it. If you make her cough and she doesn't leak urine, then she has to stand up and jump, or if she says, I leak urine when I'm jumping 100 times, then she, okay, get up and jump 100 times. Sometimes I put music because some of them say, no, it's when I go to the gym and I start to, well, okay, let's put music. And so you have to reproduce the symptom, you have to, it takes time, it takes effort, but if it's well done, it's a good tool. So the objective is to show a visual library of the normal and pathological urodynamic findings in patients complaining of lower urinary tract disorder. And we retrospectively reviewed our dynamics from 2015 to 2017, and we documented. We used a multi-channel urodynamic to record the graphics of pressure and volumes, and we included, we always done an urofluometry before the urodynamic test with the post-void residual volume. This is not in the library, but we do it too because it gives a lot of information before starting a urodynamic test. So I'm going to show you some examples of bladder sensation, bladder capacity, bladder compliance, the truthful activity, and rectal function. All this is in the feeling cystometry. So it's going to be divided in feeling cystometry and voiding cystometry. The abnormal feeling cystometry that I'm going to show you is going to be abnormal compliance and phasic involuntary detrusor contraction with or without urinary incontinence, spontaneous or forecaused, stress urinary incontinence, and urethral instability. I'm going to show you voiding cystometries. Normals with urinary phase, showing the detrusor muscle contraction, abdominal muscle contraction, and pelvic floor relaxation. We know that the voiding phase, it has to have some parameters that has to be accorded, but we have different kinds of voiding cystometry that are normals, in fact. So I'm going to show a few. And then we have the abnormal cystometry. I'm going to talk about bladder outlet obstruction, detrusor sphincter dysinergia, and dysfunctional voiding. Well, now I'm going to put the...
The objective of this video is to show a visual library of normal and pathological urodynamic findings in patients complaining of lower urinary tract disorders. The aim of the feeling cystometry is to evaluate bladder sensation, capacity, and compliance, such as detrusor activity and urethral function. In this multi-channel urodynamics, we show the graphic record of pressures and volumes over time. Measurement of the pressure-volume relationship of the bladder during filling and or pressure flow study during voiding are evaluated. Vesical pressure is obtained by a vesical catheter and intradermal pressure with an interrectal catheter. The detrusor pressure is the result of subtraction of rectal pressure to bladder pressure. Bladder filling is done by a second intravesical catheter and is also registered. The flow and voiding volume are also shown in the urodynamic. During filling cystometry, the urethral function can be evaluated by the increase in pressure induced by a cough or Valsalva at a fixed bladder volume. In this case, no urine leak was observed during maneuvers. Bladder compliance describes the relationship between a change in bladder volume and change in detrusor pressure. Normally, little or no change in detrusor pressure occurs with filling. Abnormal compliance, as shown, implies the increase of bladder pressure as the filling volume increases. Observed during the filling cystometry when involuntary detrusor contractions appear. These contractions, which may be spontaneous or provoked, phasic or terminal. The vesical and detrusor pressure show a waveform of variable duration and amplitude with no modifications of the abdominal pressure. In this case, phasic involuntary detrusor contractions that cause urge urinary incontinence are observed. In this case, involuntary detrusor contractions post-cough that cause urge urinary incontinence are observed. Stress incontinence is the involuntary leakage of urine during filling cystometry, associated with increased intra-abdominal pressure in the absence of a detrusor contraction. Abdominal leak point pressure is the lowest value of the intentionally increased intravesical pressure induced by cough or Valsalva that provokes urinary leakage in the absence of a detrusor contraction. Multiple estimates at a fixed bladder volume, 200 or 300 milliliters, are desirable. Urethral instability is the leakage due to urethral relaxation in the absence of raised abdominal pressure or detrusor contraction. In this case, involuntary detrusor contractions post-leak is observed due to reflex stimulation when urine passes through the urethra. Voiding cystometry is the bladder pressure-volume ratio during micturition. Different mechanisms of micturition can be observed: detrusor muscle contraction, abdominal muscle contraction, pelvic floor relaxation, or a combined mechanism of the three. Detrusor pressure augmentation, secondary to detrusor muscle contraction due to micturition and voluntary reflex, is observed during this voiding phase. Increase in abdominal pressure, secondary to abdominal muscle contraction without detrusor contraction, is observed during this voiding phase. The abdominal and bladder pressure have not increased, secondary to a voiding phase due to pelvic floor relaxation. obstruction is a generic term for obstruction during voiding. It's a reduced urine flow rate and/or presence of a raised possible residue and an increased detrusor pressure. Detrusor sphincter dyssynergia is in coordination between detrusor and sphincter during voiding due to a neurological abnormality. Dysfunctional voiding is characterized by an intermittent and/or fluctuating flow rate due to involuntary intermittent contractions of the periurethral striated or elevated muscles during voiding in neurological normal women. It may also be the result of an aconstructed detrusor. The visual library shows the main urodynamic findings of patients with lower urinary tract disorders, which we believe are useful for personnel in training or at centers where the surgeon does not perform urodynamic. The urodynamic is an ancillary study that completes the anamnesis and physical examination of the patients with lower urinary tract alterations, allowing to document the origin of the disorder and determine the appropriate treatment.
Perhaps there are some things to say about that we put the diagnosis, and sometimes to get the final diagnosis you need other complementary studies. But of course the urodynamic is, the propose is that you can think about that when you see this urodynamic. So this person can have this urodynamics, although I'll need more studies for go to the final diagnosis. I don't know if anyone has some question.
I think the point which we need to emphasize here is that, like you showed, that even the cuff could trigger urge incontinence. That is the difference between where the, because most of them do not actually have urodynamics, and most of them are making clinical decisions. And generally, people believe that if it is a cuff followed by incontinence, that is stress, and if it is just a desire to pass urine followed by incontinence, that is urgency. But here it is very beautifully illustrated that even cuff can provoke involuntary detrusor contraction. So mixed symptoms can be seen, actually objectified on urodynamic findings. And that can help us predict the outcome of sling surgeries or incontinence procedures that we are going to perform, the degree of success that the patient is going to have.
Yeah, that's true. We do this, I think it's this, that the patient cough and then it provokes a contraction that makes her leak. So this woman perhaps will complain about stress and she has urgent. But yeah, we do perform the urodynamics to all our patients that we're going to go for surgery, although we know that you can be justified to don't do it in women who have just a stress incontinence, pure young woman with no other disease. You can try with just the cough test and a post-void residue load. But we actually do it because it's, for us, we work like, it's like a public hospital, and it's very cheap for us, and it gave us a lot of information. So we decided to do it to every woman that is going to be on surgery. We do this urodynamic test to women that don't respond to treatment for urinary urge incontinence. We do it too. And women that have prolapse and going to to see if they have stress, incontinence, hidden. And that's the most of our indications. Then we have this woman with dysfunctional voiding. They are the lower, but we do sometimes perform urodynamics to them too.
And if you could also go back and just illustrate that part where abdominal muscle straining is being used to evacuate the bladder, because that is how the most of our elderly women are presenting, and they actually do not fall either into stress incontinence or urge incontinence. So their treatment obviously is different. So we just need to maybe explain it a little more.
You're talking about abdominal contraction in the.
The patient is just straining. Her bladder is not contracting. She's just using the abdominal muscles to evacuate the bladder.
That's really interesting. Actually, we send this to Ayuga, to the academy, and the editors, most of the editors, ask this question. It's really interesting. Which is a normal voiding, no? If it's Valsalva voiding, it's normal or it's not normal, then you will find a lot of things about this. But this case, this woman put urine all with no complaining. She said, I urine perfect, yes, I go, I sit, I do my, and I void. And she has a good flow with no residual volume high. So we consider it's a normal voiding. Rather than some dysfunctional voiding like this, that women are making strong effort and the flow is very low, and it's intermittent, and it has high post-volume residue. So this woman probably would need a treatment and diagnosis of the cause. But yes, sometimes it's not black and white. Sometimes it's a gray, and you need more tests like electromyography or video urodynamics to get to the final diagnosis. Yeah, this is more that you can ask and ask and ask. Then we have the other that perhaps is nice to show that we don't see much often. That is, this woman said that she's always leaking urine. She leaks urine and then she has to run. First we thought that it was urge incontinence, but she didn't respond, so we decided to make a urodynamic. And what we show is that she loses. As you can see here, she is losing urine, but there is no augmentation of abdominal or vesical pressure. So it's not a contraction, she's not making effort, but she loses. So we probably think that she has some urethral disease, high relaxation in the urethra. So this woman, when she comes to 20 milliliters, that's 20 milliliters of urine, she leaves all. And then the urine, when passed through the urethra, it activates a micturition reflex. That's why after this losing urine, she has a contraction, non-inhibitor contraction, with her bladder totally empty. That's nice to see. It's the micturition of the reflect activation when the urine passes. So this woman, was okay with the urge, with the treatment with drugs, with anticholinergics. She was very good with the urge, but she's still leaking. We decided to make agent volumes. As we talk with her, with all the possibility, and then I will tell you what will happen with her. And this is nice to see, because it's not so often to see. Ready? Okay. Thank you very much. Maybe
Dr. Vergamini, you have done a terrific job of phenomenally simplifying behind something which was considered a nightmare for most of us. And it's our absolute honor and pleasure for us to have Professor Prolapse with us. And she's Professor of Obstetrics and Gynecology. I will invite her on the stage to grace the occasion. Please, ma'am, please come. And I welcome Professor Shagufta Tahir over here for gracing the occasion. Thank you so much, ma'am. Please, ma'am, I will invite you on the stage. I'll further add that Professor Shagufta Tahir is Professor of Gynecology and Obstetrics, and she is General Secretary of Pakistan Urogynecology Association. Welcome, ma'am. Welcome to the occasion. The illiterates of future are not those who cannot read or write, but are those who cannot learn to unlearn. It means obsolete methods and relearn, that is, appropriate new techniques. And this workshop will empower you to accomplish this smoothly. And now I will invite Professor Nazli. She will share with us management of stress urinary incontinence with special focus on changing trends. Please give a round of applause for Professor Nazli.
Thank you so much, Professor Prolapse, that you've joined us. Thank you so much, Dr. Gupta, for joining us from Saiwan. Dr. Sadia, this is absolutely very humble on your part that you don't want to come on stage. I mean, you have a stature equal, very, very high stature in our eyes, so I would love to have you on stage.
There is no screen, that is why I...
No, there is a screen. There is a screen. So that will not deprive you of seeing the presentations on. So I'll be mainly focusing on changing trends, how we are going to treat the patients with stress urinary incontinence, what is there conventionally and what is new in this area. And we know that whenever we are talking about treatment options, non-invasive options are the ones which are going to be tried first. And what do we mean by non-invasive option? For example, if a patient is obese, reduction of weight is a non-invasive treatment option. And even if you do any surgical procedures, the results are going to be compromised in a patient who is very obese. So lowering the abdominal pressure, treating any chronic causes for raised intra-abdominal pressure, for example, constipation, for example, chronic cough, that is the part of conservative treatment. Then modification of her fluid intake habits. If she is taking too much of caffeine, if she is taking too much of liquids, or modifying the time of intake of that fluid. So that is what we are talking about, and we are saying that we are managing conservatively, and obviously the pelvic floor muscle exercises. So all these non-surgical approaches are less invasive. They do have a low cure rate as well, but improvement is often seen if patient is counseled properly and if they are explained properly, and if we are ourselves convinced, that what we are telling to the patient, we are convinced enough to convey to the patient that it is going to work. This is just like prescribing mefenamic acid to a patient who has got menorrhagia, because otherwise she's just the cabinet book. You just added Ponstone, which she could have taken over the counter for the pain. But when you tell her that this is anti-prostaglandin and this is going to act on the root cause of the problem, and this is not Ponstone just a painkiller, this is mefenamic acid, this is anti-prostaglandin which is going to address the root cause of the problem. So then it makes the difference. The way you counsel the patient for that treatment, that makes the difference. And it's just the way that in PCOS you just emphasize on the lifestyle modifications. So the same applies here, that lifestyle modifications, they come first, and although they are difficult to act upon, but if patient is counseled well, they do set a pace for improvement, and you will be able to sort a group of patients who may not need surgical intervention at all. So, and this is especially useful in those women who are considering future childbearing, because if you perform surgical maneuver in a patient who is considering future childbearing, then obviously that is going to be difficult because that mesh is not going to expand with the subsequent pregnancies. And that curative surgery might fail in a subsequent pregnancy, especially if a childbirth is attempted vaginally. But here, the big variable here is patient compliance, and response depends on the compliance of the patient. And compliance of the patient only comes with the conviction of the treating doctor. If you are able to convey that conservative management in an effective and in a reinforcing manner, and convince the patient that this is actually going to help, and you are the one who is stressing more on this and less on the surgical techniques, then she will definitely take that message home and she will act on them. The surgical treatment options have got a higher cure rate. Their response is less dependent on patient compliance. So that is the beauty of it. But obviously childbearing has to be completed. These procedures are invasive and they do have intraoperative and postoperative complications. So things are not very rosy even on surgical side. And this is especially important to understand. Why? Because this treatment is not life-saving treatment. This इस पेशेंट को आप ये नहीं कह सकते कि अगर आपने ये सर्जरी नहीं कराई तो आप मर जाएंगे, ठीक है ना? So this is just a quality of life surgery, and quality of life, especially in our part of the world, for especially a neglected gender, female gender, may not be a priority for everybody. So quality of life issues have to be addressed in a surgical way when the patient has really exhausted all the conservative options and she is fully convinced that she is now being subjected to surgery after exhausting all the conservative options. So whatever the success rate we are offering to them, she should be taken on board, and we should be able to understand, like Dr. Augustina has beautifully demonstrated, that even patients with urgency can present or stress can present mimicking urgency. So we have to be very clear in telling our patients what they are going to expect after this surgery. So I'll be talking about surgical options for incontinence, conservative options, investigations, ultrasounds, and also we'll be touching a little bit overactive bladder at the end. So what is this? Have you seen this before? How many of you have seen this before? Okay, so this is a transobturator tape. I'm very delighted to see that many also urologists have joined us in this symposium as well, because the idea is not about claiming that this is my territory and this is not yours. This is about bridging the gap. So yes, this is a transobturator tape, and this is a sling procedure where we support the mid-urethra and we treat the patients with stress incontinence. And what is this? This is transvaginal, popularly known as transvaginal tape, but retropubic tape is, the scientific name for this. So the retropubic, this is a retropubic procedure. So even in sling, you have variety. And even when you are talking about transobturator tape, you have got procedures like outside-in techniques and inside-out techniques. So again, we are perplexed which to choose, where to choose, which is the appropriate procedure for my index patient. Is birth still an option? What does the house say? Or what is the opinion of urologists? Anybody from the audience? What do we know about Birch suspension? Birch is the classical gold standard procedure which we use to perform for stress urinary incontinence, and in that, vagina is lifted and it is bilaterally supported with iliopectineal ligaments, and urethra is thereby compressed between the vagina and the pubic symphysis. And that has been the gold standard procedure so far, unless the sling procedures are taking over. So, yes, I don't think that the Birch is still out. Number one, because it is the gold standard procedure. Number two, many of our patients, they are actually so poor that they won't be able to afford a sling, which is costing them 36,000 rupees, and just the sling, and the cost of surgery is in addition to that. So, and if particularly you're performing an open abdominal procedure, you're already doing an abdominal hysterectomy, and that patient is being treated simultaneously for incontinence, I would rather go for a burst corpus suspension because I can use the same approach, and that is going to be less, add less morbidity to the patient. So what is the overall cure rate of retropubic versus transobturator? Or you can say, what is the overall cure rate of TBT compared to TOT? So here you see retropubic versus transobturator, and the odds are generally equal. The thing is just that for retropubic or transvaginal tape, we have got a very long-term data, like it is there for 20 plus years. And the transobturator tape is in place for the last almost a decade now. Most of the data that we have is for the last 5 years, so we can say that the long-term data of transobturator tape is relatively less as compared to the transvaginal tape. So for transobturator slings, we generally have 5-year results available, but obviously the 5-year results are also evidence-based. What is the patient cure rate if the genuine stress incontinence has been properly identified, if you have not chosen the wrong patient for the surgery, and if you have addressed, the preoperative concerns, the conservative options preoperatively, then the cure rate is as high as 90%. And this is a pretty stable cure rate. So I am confused here. Which tape should I use? Does it make a difference? Or it doesn't make a difference whether I use a transobturator tape or transvaginal tape? Mostly, you can say it doesn't make much difference, but there are exceptions. There are exceptions where you will prefer one tape over the other. So when should I always use a retropubic tape? Just a transvaginal tape, not a transobturator tape. If the patient has got recurrent stress incontinence, you have treated her once and she is reported to her with a failure. So obviously then the transvaginal tape has got a longer data, almost twice as long. Then you will not subject her to the same procedure again. You might go for it. And if there is intrinsic sphincter deficiency. So we'll talk about that. If we identify that this is not because of a hypermobile urethra, this is basically just a weak sphincter, then retropubic would probably be a preferred option over the transobturator tape. So how do we diagnose intrinsic sphincter deficiency? This is what Augustine had discussed with you by urodynamics, where we see that the leak point pressure is at less than 60 centimeter of water. That is, the abdominal pressure is raised less than 60 centimeter and the patient is leaking urine. And the Q-tip test, if you do not have urodynamics, we don't have fancy urodynamics at every place. In Lahore, we have them at Shalamar Hospital. I believe we do have them at Sir Gangaram Hospital as well. And Europhometry is a couple of other places, but not the full-fledged urodynamics. So what clinical things can help us? The Q-tip test, if it is showing the deviation of the urethra less than 30 degrees, so that is probably not a hypermobile urethra. And if this patient is leaking urine, then she is a patient most likely of stress incontinence due to intrinsic sphincter deficiency rather than hypermobile urethra. But obviously, this is a compromised, diagnostic maneuver. The gold standard will be the urodynamics. So this is the Q-tip demonstration. You pass a lubricated cotton bud through the urethra, and the female urethra is about 4 centimeters long, and you just cross the sphincter, and then you ask the patient to perform Valsalva. And this is a 30-degree angle. You don't have any vernier calipers here. It is just like seeing cervical dilatation. आप जितनी पीवी कर रहे होते हैं उतना आपका हाथ उस पे सेट होता जाता है कि this is 3 centimeter dilated, this is 4 centimeter dilated. Consistency भी cervix की it is just a subjective thing. So here also you get a clinical experience that this is almost 30 degrees or less than 30 degrees. So when should I use a transobturator then? Transobturator is to be preferred if patient has got multiple previous abdominal operations. If that patient has had hysterectomy in the past, myomectomy in the past, 3/4 cesarean section in the past, I would rather be very reluctant to do a transvaginal tape because I do not want to come out through the suprapubic area because that is the area where bladder might be inherent. I will increase the risk of surgical complications. So I would rather try to stay away from that territory and work in the obturative area. And if I'm not comfortable with the retropubic route, if I do not have it, it's like convenience of the surgeon. And then there are now we have got single staining CNs as well, but because I've never performed them and I don't have much experience about them, I won't be describing them much here. And this is the classical bulking procedure which was performed urethral meatus. We see on the cystoscope and we insert the bulking agents around this. Now this has also been by and large replaced by the retropubic tapes. So laser. We are increasingly hearing about laser these days. Laser for the treatment of stress-relieving incontinence. Is it really there? So here we see a device which is placed in the vagina and the target area is focusing on the base of the bladder. So what is this laser going to do here? This is basically not tissue ablation effect here. We are used to using laser for ablative procedures like in endometriosis, like in endometrial ablation, hysteroscopically. Concept about laser therapy and for cosmetic reasons, hair removal and all that stuff. So most of our understanding of laser is that it is going to ablate something and that thing is going to vanish. We do not want the base of bladder to vanish. So here the laser is being used in a modified way just to cause the cell activation to promote increased collagen synthesis in this area so that this area is rejuvenated. So there are specific target rates. And this procedure, I think, is being performed now at Hamid Latif Hospital. So, so yes, we have got it, and I think it will be in the toolbox of most of us very soon. So, photothermal effects are just as deep as 0.5 millimeter and 30% reduction in tissue volume, and it causes a mechanical pull by the deeper layers. Thermally induced neocollagenesis, which improves thickness, elasticity, and firmness of this area. So there is significant improvement in scores on international consultation incontinence questionnaire. This is the feedback, and this is the 6-month follow-up of the patient who has had a laser treatment. Okay, give me a little break here, and I'll just take a break because somebody so honorable has entered the hall. I welcome Professor Arif Jamul. He's President, Pakistan International Representative Committee of Royal College of Obstetrician. Thank you so much, sir, for being here.
It's an honor to be here.
So we just touched the you can see there, it's in front of us. So we just touched the surgical options we had for stress-relieving incontinence, and we touched the dimensional medical therapy, and she is not responding. Then probably she is a patient where we need to see whether she has got some other hiding stress incontinence like Augustina just demonstrated. And if we are unable to demonstrate stress incontinence on examination, your patient tells you that she leaks on coughing, but when you make her cough in the clinical setting, those symptoms are not being reproduced. And you do want an objective confirmation of the symptoms of the patient. Yes, urodynamics have a place over there. Profound voiding dysfunction symptomatology. So if a patient is coming to me that she is straining in the toilet for 1 hour, yesterday I had a patient who said that she takes 1.5 hours to complete her voiding. So I cannot subject that patient to an obstructive surgical procedure, to a sling procedure. I need to be very sure that she has a voiding problem. Because of some resistance in the urethra, the sling is going to add to her trouble. It is not going to relieve her trouble. So there also you need to identify what voiding dysfunction she has predominantly and how we are going to address that. Recurrent stress incontinence. Again, if you have performed Birch-Colfer suspension while performing hysterectomy and your patient comes back to you with a recurrent stress incontinence, you should at least have an objective diagnosis at that time before proceeding on for another surgery. And if there is an unexplained incontinence after prolapse operation, we need to understand this, that in a patient with prolapse, generally the urethra is kinked because of prolapse. And generally the incontinence symptoms might not be clear at that time, or the patient may actually be presenting with a voiding dysfunction, voiding problem because the urethra is kinked and obstructed. And once the prolapse is reduced back and urethral access is restored, and that is the time that patient may present for the first time with an incontinence. So these are the cases where urodynamic investigations should be performed, so that whatever you are going to do in future is based on scientific evidence rather than just hetero trial. So is ultrasound an option? Yes, ultrasound is an option. I wish we had Dr. Sabdar Malik here. I called him yesterday and he really wanted to speak on this aspect, and I promised him that once I reach this part, I'll invite you on the stage. I think he is unable to make today. So ultrasound, yes, perineal ultrasound is the best in these patients. And you can see urethra. Here you see the bladder, and you can measure the bladder volume, which can obviously be measured on a transabdominal as well, and obviously on a transvaginal as well. But perineal ultrasound is specific for these patients. So bladder dimensions being shown here. Here you see this is the urethra, this is the bladder neck, and this is the bladder. And we have asked the patient to perform Valsalva, and you see the bladder neck has descended to this place. So a bladder neck descent of more than 2.5 centimeter is considered to be hypermobility. If you do not have a fancy ultrasound, you just need to put your patient in the Sims position, retract the posterior vaginal wall with the Sims speculum, and ask her to perform Valsalva, and you can have a look on anterior vaginal wall, point AA on anterior vaginal wall, 3 centimeter above the urethral orifice, and if that is hypermobile, this is a patient with hypermobile urethra. So I'm giving the options, just the clinical examination options, because we do understand that we do not have technical facilities available at all places, so what compromises can we make? So this was by and large a short overview of the recent trends in the management of stress incontinence. So what is trending in overactive bladder? Overactive bladder treatment, we generally think that this is less invasive. Well, it can be very invasive as well. So we start here and we can end here, anywhere here, or we might have to finally land here. So what is this less invasive? Again, the lifestyle advice. Lifestyle advice, lifestyle advice, lifestyle advice. I cannot overemphasize it. So, and behavioral approaches. Regular voiding schedule. I have translated the International Urogynecology patient information leaflets into Urdu in collaboration with IUCAN. 5 of them are available with me. I can share them with you. I have got bladder diary now in Urdu available. I give it to my patients to maintain that bladder diary and come back to me after a week. And it is surprising, so many patients are just, identified, their problem is identified on the bladder diary. And we can just advise them fluid modification, and that's it, and they do not need anything else. Then pelvic floor muscle exercises. Are we really teaching them well? If you just tell a patient who has walked into your office and you just tell her, tighten your muscles like, the way you tighten them to hold the urine. Is this objective, or does this order have a lot of subjectivity in it? You try to do it in your clinical setup. Most of the patients will be contracting their abdominal muscles. You place a hand on the abdominal muscles and you will be surprised to see that the patients will be contracting abdominal muscles along with pelvic floor muscles, and they are actually performing Valsalva, which is aggravating their symptoms. So are we actually putting 2 fingers in the vagina to tell them that these are the pelvic floor muscles which we actually want you to contract? with her second hand resting on her abdomen, telling her that these are the muscles which need to stay relaxed. So just the pelvic floor muscles need to be tightened and not the abdominal muscles. And then it has to be a controlled contraction and a controlled relaxation. And only that is what is going to improve her symptoms. If we just tell her, casually walking, कि इस तरह टाइट कर लिया करें 10 दफा सुबह, 10 दफा दोपहर को, 10 दफा शाम को, which 99% of us are doing with due apologies, it will not help us. It will not help the patient. And then manage the fluid intake. Majority of the patients are taking caffeine, carbonated drinks, a lot of fluid, and they are not understanding that water and other fluids, they add up in the total fluid intake. So they are obsessed about taking 3 liters fluid for a good skin, and then 3 cups of coffee to stay awake, and all that adds up. So we are progressing on this line. Your patient is not responding here. Urinary incontinence products you may have to use, and you may have to teach her intermittent self-catheterization. Pharmacotherapy. Generally we jump straight here. Most of us are jumping straight here. Antimuscarinics, estrogens, beta-3 adrenal receptor agonists. This is now the 4th. Neurostimulation, posterior tibial nerve stimulation. I am delighted to announce that we have got a pain clinic now at National Hospital Defense, and we are doing now the nerve stimulations as well. That is going to be part of our armamentarium. So posterior tibial nerve stimulation can be used to modify the symptoms. Botox. Sacral neuromodulation, more invasive, therefore later on the line. And finally, augmentation, cystoplasty or urinary diversion, which is very, very rarely needed. So what is new here? There is a product. This is Mera Vecron. So this is not available in Pakistan. I have never used it, but I've just taken this data. What it does is that in different to most of the anticholinergics that we are using, which are antimuscarinics, it basically augments the sympathetic actions here and it increases relaxation. So it has got an alternative mechanism of action, and we are hopeful that this might be a better alternative in those patients who have got some contraindications for antimuscarinic therapy, for example glaucoma, etc. So this is Botox. We introduce it through a cystoscope, and the needle which is used, and at multiple points Botox is inserted. Sir Zaki, I just seen you, you're here. Why don't you please come on the stage and join us here as one of the chairpersons. He has always been such a wonderful support, a person who I always back upon. And yesterday when we were having real doubts whether Augustina is going to make it or not, he was such a humble and down-to-earth person that he offered me his services to be available for the entire day, and I cannot thank you more than this. Please come here. He is a urologist, and he is in charge of Sharif Institute of Transplant, renal transplant. And he's always, even if he just says yes to me for everything, वो पीछे हाथ ही काफी होता है, तो आपको so he's that sort of person for me. So this is Botox and sacral nerve stimulation. We are not doing it. We have started it now, the pain clinic in National Hospital Defense, and we might be doing it very soon. And so this is invasive procedure. You have to place the device inside the patient's body. So posterior tibial nerve stimulation is better. Yes, this is because it is less invasive and it does not involve a permanent implant placement, and mode of action is that it causes neuromodulation of sacral nerve plexus via posterior tibial nerve. 30-minute session each week for 12 weeks. This we are starting soon in our pain clinic. So finally, this stage hopefully shouldn't arise where patient needs intermittent catheterization or indwelling catheterization or permanent suprapubic catheterization. Thank you very much. So these are the very advanced procedures which we do not generally do, but for the sake of completion, they are there. Any questions or comments? Surgical procedure is not free. Surgical procedure we have two options. It's very good. Thank you so much for highlighting here. We have got two options here. We are running a regular Urogynae clinic at Shalimar Hospital, which is a trust hospital. And the patients who come there, they are booked as general patients. And once they are there as general patients, the surgical procedure is completely free. They are only paying the cost of investigations and medicines. So very nice of you, Dr. Farid, to get it, regurgitated from me. So surgical procedure is free, and we also had a free fistula camp. It is in collaboration. Shalimar Hospital has got collaboration with Pakistan National Forum and Women's Health, and we performed a free fistula camp where all the treatment is absolutely free. The stay is free, the surgical treatment is free, the investigations were free, the medicines were free. In the last camp, we treated 5 patients, and you will not believe that even those 5 patients needed at least 200 calls from me, because most of them had failed surgery twice or thrice before, and their confidence was so shattered, really so shattered, that they were not turning up even for a free fistula camp. Despite my repeated reassurance that we have got a team of experts, Professor Aziz Abdullah had also joined us from Karachi. So it was not like a solo performance by me. It was a joint effort by a group of very committed people. And patients then finally had surgery, 5 of them. And they kept on coming to my clinic for 3 months post-operatively with the doubt that they are still having incontinence. And it took them next 3 months to believe that they have been cured of incontinence. डॉक्टर साहब अभी भी लगता है, कभी लगता है, हल्का सा आ जाता है. So it does happen. So yes, but if you are coming in a private setup, surgery definitely costs. Thank you very much. It's time for tea, and let me check the arrangement.
The glory of medicine is that it's constantly moving forward, and there is always more to learn, and research is a tool for moving forward in right direction. And now my next honorable guest is Professor Shagufta Tahir. She is Professor of Obstetrics and Gynecology and General Secretary of Pakistan Urogynecology Association. She will share with us prevention of stress urinary incontinence and prolapse. Please welcome her on the stage, Professor Shagufta Tahir.
Assalamu alaikum. Thank you very much for giving me the honor to present my presentation. I change my presentation क्योंकि पहले मेरा प्रोग्राम आज का नहीं था, फिर वो आज का हो गया. तो ये कुछ तब्दीलियाँ हुई. So I change my presentation. इसमें हम आज बात करेंगे इस मौजू पे, that is how we can prevent the pelvic organ prolapse. And the pelvic organ prolapse and pelvic floor dysfunction, it is a very distressing sort of the problem. Our population who are nutritionally deficient and they're poor, they are suffering it. Plus we have got the certain things in it, What we can prevent is that, because they are the women, they have to bear the children. A woman who have to bear the children multiple times, they bear the grand multiples, and they deliver at home. So when they deliver at home, they do not have the proper services who can protect their pelvic floor. Automatically they push before the cervix is fully dilated. So once they start pushing before the dilatations, what happens? Basically they push the floor to come out. This is the way how we can get it. Another thing is that they have genetically and nutritionally prone to it. So pelvic floor dysfunction, it constitutes a huge global health problem affecting the hundreds of millions of women throughout the world. Prevalence of one form of the pelvic floor dysfunction is 46%. You can see the urinary incontinence, fecal incontinence, and the prolapse. And lifetime risk for a woman to get the surgery for the prolapse is around 5 to 19%. We can see the etiology. On etiology, it's very huge. You know, there are multiple factors involved in it, and basically that is the obstetric trauma to the pelvic floor during the childbirth. And one of the most risk factors is also like the obesity. We can discuss the obesity is increasing day by day because of the people who are having the sedentary lifestyle, family history, and aging. You know, they get aged when age of about 40 years, and grand relatives, they have more chances. And then high therapy, weight of the baby, they were delivered the large vacuosomic babies, home deliveries, as I said. And after the birth of the first child, the increased prevalence is observed in some of the studies. Now, the question arises, whether this increase is due to the pregnancy per se, we can say, and is it related to the childbirth? Whether the pregnancy, carrying the pregnancy with the 9 months is the reason of having the descent of the pelvic floor, or it's something like a person who has given birth and trauma of the birth and the mode of delivery. Whether the woman should go through the spontaneous vaginal deliveries, or she can have the baby with a cesarean section. Nowadays, the people are talking about there's the posh people, you know, they're difficult to push, so they're too posh to push. They do not want to push, you know. So they want to have a cesarean section for 1 or 2 babies. They want to save the pelvic floor. And I need to conduct the research on it, whether they should pass through the process of the childbirth to get the answer of all these questions. Now, how to answer? Now, the randomized controlled trials to evaluate the causal effect of the vaginal and the cesarean birth on the future pelvic floor dysfunction have not been performed up till now due to many reasons. So we need to rely on the objective pathophysiology data and epidemiological data to evaluate the effects of the vaginal delivery. Now, the effect of vaginal delivery, what it does basically, the difficult vaginal delivery is including like forceps vaginal delivery, and it is associated with the bad effects, you know, and prolonged second stage. Now, when the woman is pushing against the pelvic floor and she is not getting the delivery and end up onto the cesarean section, that is also one of the insults to the pelvic floor. High infant, high weight, birth weight of the infants. All of the above risk factors, they are associated with the stretching. Basically, what happens during this process, it causes the stretching and then leading to the nerve damage and ischemia, compression of the nerves, and that leads to the difficulty in that. Now, what is the clinical evidence of it? If you do the ultrasound, MRI, and electrophysiological techniques can be utilized to diagnose it. You know, most of the places we are not having it in Pakistan, in fact, and if we start establishing the services so we can get all of these things in one roof. So DNC, he reported it. Occurrence of the levator and eye damage following the spontaneous vaginal delivery. And he said that 6 to 10%, but following the forceps delivery, the much higher occurrence is about 60 to 70%. And it was observed in different studies. Now, in an ultrasound study by Gates and Mr. Lanzaro, they reported the detachment of the levator and eye. You know what happened to the levator and eye? It is attached to the side bones of the heart bony pelvis. So when the head of the baby passes, it carries the pressure. Now with that, it evokes the ligaments. So what happened basically, levator and eye, it get detached from its attachments. So that was presented in 14 out of 39 women who were examined for the vaginal delivery after that. So which was associated with stress urinary incontinence later in their life, and 3 months, usually they have 3 months postpartum, even they continue with that. So what to do? This was another study which was very popular, Apricot study, and that demonstrated 1.74 increase in the age-related risk of the urinary incontinence after 1 week or more of the vaginal delivery as compared to the cesarean section. So the people are comparing the cesarean birth as compared to the vaginal deliveries for that. Age standardized prevalence rate about for the urinary incontinence was 15.9%. For the cesarean section group and for the vaginal delivery group, it was higher, that was about 21%. In the same study, they found this. The other studies were performed, they also indicated that increased risk of the urinary incontinence, pelvic organ prolapse, according to the vaginal delivery, it was higher as compared to the cesarean section. So Swedish study, another, they did on to obese patients. So they found that the obesity and the pelvic floor study that was done, it was designed for the specific aim of comparing the prevalence of the pelvic floor organ prolapse after the 20 years of the last delivery of the vaginal delivery and the cesarean section. This was a very long-term study in fact, and they followed the women after the 20 years. So the result of this study was they found the prevalence and the risk factors for the urinary incontinence, pelvic organ prolapse, and symptomatic women having the fecal incontinence after the 20 years, and it was after one for more, that's the vaginal delivery as compared to the cesarean. So the increased risk of developing the urinary incontinence, it was found to be 67% after the vaginal delivery as compared to cesarean section. So they adjusted the odds ratio, 1.67, the odds, statistical analysis. No difference onto the occurrence of the urinary incontinence in the women with the emergency cesarean section and the elective cesarean section. But later stages of the labor, it leads. When you do the cesarean section after the prolonged labor, that gives the difference. It was about 225% increase the chances of having the prolapse. So the pelvic organ prolapse risk increase with the increase in the body weight. If the women take up the weight, any part of the life, maybe after the 40 years, so they have more chance of developing the prolapse and they have more chances of developing the dysfunction. So every 100 grams, this was when you noticed, increase of the fetal weight, that increases the risk to the pelvic floor. So we can predict, can we? And how we can prevent. So informed choices should be given to the patient. So we can give them the choice whether if they want to continue the vaginal delivery or if you want to have the delivery by the cesarean section, you can protect your pelvic floor. So this is also very important information you must share with the patients. If they want to have it, it's no harm in it. So based on the results of the prolonged SWEET-PAP studies and the other studies, hypothesis, it's your choice. Recently we had one of our last year biennial conference in Saiwan, and there we invited one of the international faculty, and he was the professor of emeritus, Don Wilson, and he talked about this, your choice. So he said, okay, we must give the choice to the patient whether they want the delivery vaginally or they want to have a cesarean sections. And as we give the people the information regarding the other things like anesthesia, the blood and all that, so we should tell them as well, if they want to have, they are more concerned about the pelvic floor, they are concerned with the lateral episiotomy and having the problem with episiotomy, fecal incontinence, so they can be given the chance that if they want to have not more than 1 to 2 children, they can have by the cesarean section, if you want to protect the pelvic floor. So it has been now put forward and based on the available data. So scientific evidence, the features of the mother and the baby can be scored and used to determine the most suitable route of the delivery to avoid the pelvic floor descent. So your choice means it is the abbreviation of presence or absence of antenatal urinary incontinence. These are the things on which base we can give the choice to the woman. Either she had already the urinary incontinence, any episode, race and ethnicity of the person. Then childbearing started at what age? If she started earlier, height of the mother, it matters. Pelvic, the cavity, because we can say that if the mother is a short stature, the more chances that she is having the contracted pelvis. Small pelvis. Overweight mothers, having a more weight, BMI is high. Inheritance, the family history. And then we can look for the children, number of the children they desire to produce. So these are the things what we should consider. And E is for the estimated fetal body weight. So we must look at these factors and then we can decide and give the chance to the woman whether she wants to deliver vaginally or whether she wants to have cesarean section. So I will conclude, women is increasingly involved in their decision making. process after the individual risk assessment and counseling can be much easier regarding the mode of delivery. Right? So the trend is clear. In developed world, and the woman is older when they bear the first babies, and as I said, they get and the heavier as the mother becomes, and they have the more BMI. So UN data suggesting the total fertility rate worldwide is decreased globally, and it's like they are not having not more than 2 children per family. So cesarean section offers the protection from the urinary incontinence, and they have a pelvic protection from the POP and fecal incontinence. So Ingrid Negert, he raised the question. This was a person he said that should the women be offered the elective cesarean section in hope of preserving her pelvic floor, but the cesarean section cannot be performed on all of the women. So there are documented potential risk factors with the operative delivery. So what to do? So recommendations, what we can do. So the predictive model, which estimates the individual risk, can be used. Like as I said, your choice. It's a model, then in the people system. Can be used to make the informed decision by the patient and the healthcare provider to prevent the pelvic floor dysfunction later in the life and choose the most suitable delivery, mode of the delivery for the next patient. Thank you very much. Any questions? Any comments? Yeah.
I am very interested in the presentation. No, my question is if you show the ultrasound,
Transformator ultrasound is available. I think it's
for the diagnosis of the abortion of the recurrence.
Actually, it's not being done because the transperitoneal ultrasound, I think few of the people are doing it here now. In Karachi, I tried to pursue with the Dr. Musarraf. He said, hey, I have to look into it now. So people are doing it now. But we can relate it with the MRI, MRI. But if you are really interested in knowing that,
Incontinence procedure. So we prepare a lot and we still use it because we are in protocol, but we are not more advanced on that because we see some difference between the video. But since the DX public that you showed, that it seems like one birth is enough to make an
reduce the
abortion.
problem, yeah.
of
And
the
they say,
recurrent.
because if you consider a person who has delivered vaginal birth and the person who has got a cesarean section, and after the 20 or 25 years later, the women who have the cesarean, of course, the elective cesarean, they do have the same problems. There are other factors which are included. That's why you cannot predict, you cannot give the choice to continue.
Yeah, of course, but what I'm saying is perhaps now we are turning the ultrasound, we are doing the...
You want to do ultrasound for everything?
No, well, that's what I'm saying, that we are thinking about if this is a tool for doing to women who we can do ultrasound, and those who have elevator and abortion, then should we do this would this woman relative muscle and training to prevent prolapse and incontinence? Because we have a problem in Argentina that we don't have time for the teaching that we have muscle and traination training. We don't have enough time to, we do have a physiotherapist that works with the women who have prolapse and incontinence and those who wants to prevent to have it. But we don't have enough time, if you want to schedule an appointment, you will find it in 4 months or 5. So we start to ask which of these women could be suitable for pelvic floor. So we then saw the publication that you put about DX that says that those that have birth and ovulation, of the elevator anus, then this one could be a chance. So I say, well, it's not all the women. We now have the half of the woman, so perhaps it's a good tool for that. No, I ask you if you did that because perhaps you done. We are starting to do it, so we don't know.
We are just planning,
Yeah.
where is the BC?
Yeah, well,
We are just planning to do it, but inshallah we will do it. Maybe
Yeah.
in your next visit to Pakistan, we will
Yeah.
be able to give you the answer.
Yeah. Oh, we should call yes.
Now
Yeah.
you want
Ultrasound is very easy, but
you want to say
you
something?
need. Ultrasound it's a very nice tool and it's easy because you can do it with the one that you have with your echography. But if you want to do the 3D, the ultrasound of the elevator, that more is complex. But the normal is totally
Transcranial ultrasound is different. We are talking about the
transcranial, sorry.
damage of the levator.
Yeah, that is different.
So for that,
you
we
need
need
the 3D.
another ultrasound.
Yeah.
We are not having it.
Yeah.
Anal probe, and you have to do that.
Yeah.
So that thing can diagnose there is a defect into the sphincter or not.
Yeah.
If you diagnose it pre-hand, then you can go for refractive surgery. Second, all you can repair it. In fact, 22% of the women, they are not aware of it that they have got a third degree, fourth degree pregnant care. They do have one of the this problem, like they have silent damage to the liver canal.
Yeah, of course, they are just like symptomatic and they are talking about it, so yeah, it's nice to know who these women are.
Hope in the line.
Yeah, well,
You
it
have
has
to
to
develop that ultrasound. Our small facilities, we have to talk to them.
Wow. Thank you.
Thank you.
Dr. Deepa Sadiq from THQ Hospital, Wazirabad, as a consultant gynecologist working there. My question is that for every laboring patient who delivered vaginally, is it recommended to have pelvic floor exercises before the development of symptoms for incontinence?
Great question. You asked me a very lovely question. Thank you. I just forgot to talk about that. Actually, prevention is with the from the antenatal period. We must tell our women, as Dr. Nazli, she explained how to do the pelvic floor exercises. So this must be taught by the physiotherapist or by the gynecologist to the women while they are coming for the antenatal visits. And at the time when they deliver, immediately postpartum, we must continue that for the next 3 to 4 months. Then the patient will definitely get benefit, but it has to have, even very religiously, you have to do this thing. You just don't do like maybe aapne bata diya usne kiya nahi kiya, so then you won't get the result. For the Kegel exercises, you need to be very religiously stick to it and demonstrate the person very accurate method of doing it. And I put the 2 fingers in the vagina and one on the hand over the abdomen. So the woman must not be contracting abdominally. She should have this, get hold of the urine, So you feel the constrictive ring around your fingers. If you put the 2 fingers and ask the woman कि आप अपने आप को tight कीजिए नीचे से, अपने आप को जैसे आप urine रोकते हैं. So you can feel there's a ring constricting vagina में आपको feel होगा. And that is the levator muscle. So if you are continuously doing it, so what you do basically, you are stimulating the nerves. That's a pudendal nerve. The bundle of the pudendal nerve which passes through the pudendal canal, and when it is birth, vaginal birth with that, and everything died down. And so, how much time the head of the baby stuck over there? I mean, if it takes more than half an hour, so it's enough to causing the pressure onto the nerves. So that is one of the reasons later on. And so dragging cessation, and the patient feels something lump coming. Even there's no prolapse, they tell you, I feel the lump, I feel something coming down. So always give them the trial of the Kegel exercise to every patient who wants to deliver vagina. I think this is a very good practice. We must introduce in our antenatal wards. Yeah.
My question regarding personal choice of mode of delivery, as you have said. On the one hand, we say that we should not encourage personal interest for elective low segmentation section because of the risks and morbidity associated with it. And also, you have told that when in one study we have found that after 25 years there was no difference in the risk of prolapse and incontinence in patients who underwent normal vaginal delivery of cesarean section. So then should we encourage on the basis
as I said
that
sentence kaha tha, too posh to push. There are some people like celebrities, like hamari educated class, they cannot take the pain, so they are not willing to push, So these are the people who are really interested in going in cesarean section. And if they are interested to prevent their pelvic floor and their all things, okay, you can give them.
Even we said it, even if elective cesarean section, there's somewhat damage to the pelvic floor, obviously, because of the pressure of the baby. It's
For
not
9 months. Continuously
obviously,
tap down the pressure, which is, yeah, you're right.
So my question is that I think we should not encourage the sole factor for elective cesarean section in order to prevent damage to the pelvic floor. Just for that, no, we should go on the
We are with the same mindset. We do not give. Yeah, we do not give. But the trends are changing in the world. So I gave you the trend which is changing in the world. Yeah, हमारा trend नहीं है. Because we are in the third world and we are not having the facility of this thing, and we are having. You must have seen the increasing rate of the placenta previa. लेकिन ना कितना बढ़ गया. And there are a lot of the complications of ruptured uterus के साथ आ जाते हैं. They get the trial, the third, after 2 or 3 cesarean section by that. What you will do with them? Obviously. So हम लोग तो we are stuck with them now. So we can not offer to anyone, you know. But this is what the international level where what is changing. These are trend is changing. The people think like that as well because they are concerned with the pelvic floor. We are not, of course, we are concerned with the life of the person. This is something to prevent give the good, healthy life, you know. And we want to save the life. We have most of that. Our domain is a little bit different, but we must have the thought of that as well. No? We are discussing it. Thank you. Right.